Thank you. So many mornings, my kids wake up, run into my room, and peek through the blinds at Sarah, the homeless transgendered woman who sleeps in the park across the street from our house. They get that Sarah's unwell. They watch as she splashes water over her body, as she speaks to unseen tormentors. They also get that she's a survivor. She's there in any weather, rain, snow, -20, +30. There's been a low-level war running through our neighborhood over Sarah's presence in the past few years. But to my kids, she's nothing less than a neighbor, an essential member of our community. My eldest daughter drew this picture a few weeks ago, which shows different types of homes in our community. Apartment, two-story, semi-detached, and street. My kids ask many questions about Sarah. Why does she have a woman's name and a man's body? Why does she speak to people or things that we can't see? Where does she eat? These are questions I can usually muster up some semblance of an answer to. But then there are the questions I'm at a loss to explain. Why doesn't Sarah have a home? Where's her family? Why can't she just move into our basement? How can we help her? Now, these questions bring up a familiar feeling of powerlessness in me, feelings I remember from my first years in practice. I'm a family doctor. I work in inner city Toronto. I've seen lots of people who've experienced homelessness and poverty. In fact, I've seen a lot of people like Sarah. But despite all the usual interventions, the Sarahs in my practice just didn't seem to get much better. And it's those questions I couldn't answer that kept running themselves through my head. Maybe there was something I was missing, something else I could be doing for my patients. And so this is the journey I want to take you on today. From a feeling of powerlessness to opening new windows on what we can do as doctors to really improve our patients' health. To frame this for you, I want to give you a little bit more of a sense of who I see in my office and the stories they tell me. This is Wanda. I've known her for 8 or 9 years and probably seen her every month or two in that time. She's 52 years old. She has multiple sclerosis and heart disease. She lives alone in a downtown Toronto housing project. Her mind wanders in and out of lucidity as her body lets her know day by day what it's going to allow her to do. She relies on a handwritten sign on her door to keep the crack dealers away. She's watched her closest friends die young. Her husband left her a few years ago because he was just too exhausted from trying to care for her without any other supports. She manages to survive but lives in squalor on $1,000-odd a month. She's told me she would love to have a nicer apartment in a safer neighborhood. She'd love to go to a movie once in a while, have some help with cooking and cleaning at home, maybe even take a vacation. She had this once, but she can hardly imagine it now. And this is Teresa. She's a young single mother of 2 small children who left Toronto a couple of years ago for a smaller town outside the city to get her kids away from the bustle of city life. She struggled through and finished a part-time nursing program, but she's been stuck on welfare for a lack of childcare. The last job she was offered, she had to turn down because it started at 6:30 and her daycare only opened at 6:30. Now she can't even get out to job interviews because she can only get a daycare subsidy once she has a full-time job, and she has no one to care for her kids during the day. She came to me asking for help with stress and depression. Now, I did everything I was supposed to do for the Wandas and Teresas that I saw. I prescribed them the right drugs, I ordered the right tests, I referred them to the right specialists. I told them to eat better, to exercise more, to seek counseling for their mental health. But despite all this, they just weren't getting better. In fact, they were as debilitated, as stressed, as unhealthy, pretty much as the day I met them. And so it left me thinking, was there something I was missing in what I was doing? And it was pretty obvious to me what the problem was. I was treating their bodies, but not their social situations, and especially not their income, which seemed to be the biggest barrier to their health improving. The research evidence was pretty clear on this. Income, poverty, is intimately connected to my patients' health. In fact, poverty is more important to my low-income patients than smoking, high cholesterol, high blood pressure, obesity, salt, or soda pop. Poverty wreaks havoc on my patients' bodies. A 17% increased risk of heart disease, more than 100% increased risk of diabetes, 60% higher rates of depression, higher rates of lung, oral, cervical cancer, higher rates of lung disease like asthma and emphysema. In Toronto's poorest neighborhoods, a 60% higher rate of infant mortality. And then there's what's been called the toxic stress of living in poverty. And this we can actually measure in my patients' bodies, in higher levels of stress hormones and other biomarkers, even down to alterations in their genes. So through all this, it became pretty clear to me that I was treating all of Wanda's and Teresa's health issues except for the most important one, their poverty. And so I realized that we needed to bring poverty out of the periphery and right to the center of what we do as doctors. And so I decided to start to treat poverty not as a social or a moral issue, but as a disease, to be diagnosed and treated like any other. That's easy enough to say, but there really is nothing in the traditional medical toolkit geared towards treating income as a disease. And this is what doctors told me over and over again. They said, why should we spend so much time on something like poverty when there's nothing we can do about it? Luckily, a couple of years ago, I was shown a way through this quandary. I was asked by an anti-poverty organization called the Ontario Coalition Against Poverty to participate in clinics focused on one purpose, to fill out forms called special diet forms that provide people living on social assistance with up to $250 a month in extra income for dietary needs. I was brought out to community centers, drop-ins, libraries. I was sat down behind fold-out tables, often behind rough cardboard barriers, and I was asked to prescribe income to people at the lowest end of our income scale. Now, to give you a sense of the challenges these people were facing, I'm going to take a poll. I'm wondering if you can tell me what you think a single person living on basic welfare in Ontario receives every month. This amount meant to cover everything from rent to food to transport to clothing. I'm going to give you 4 choices: $600, $900, $1,100, or $1,400 a month. Hands for 6, 9, 11, 14. The answer? $600 a month. Don't worry, most people I ask this question to have no idea of the right answer unless they've actually lived on welfare. And to call this subsistence living is insensitive. In fact, it's completely out of touch with reality. Almost no one can survive on $600 a month in Toronto. We actually asked people coming into our clinics a simple question. We said to them, after you've covered all your other expenses, how much do you have left for food every month? The answers, for someone on basic welfare, an average of less than $1 per day. For someone on disability supports, just under $4 a day. That's less than many of us spend on our daily cups of coffee. So to be able to prescribe an extra $250 a month to these people was astounding. Our climactic moment came when we set up a clinic on the lawns of the legislature at Queen's Park, and 40 healthcare providers prescribed 1,000 people living on welfare this supplement. I've never seen my patients so consistently thankful, so joyful about something I've done. Unfortunately, the government, not having budgeted for the true needs of people living on social assistance, changed the program, changed the forms, and stopped us from being able to carry out these clinics. But I was left with the emotional rush, with the feeling that I had finally found a way to plug up that hole in my skills. I prescribed income. Here was a way to maybe bridge that gap between my mandate to improve health and my professional inability to do so. So I turned my mind to this one question. What can we, as doctors, do to actually treat our patients' income, actually deal with their finances? In fact, I became obsessed with this question. I went to bed reading fiscal policy. I dreamt of RRSPs and tax breaks and tax-free savings accounts. And through this all, it became clear that the answer actually lay pretty close to home, that there were things that we could do as doctors in our day-to-day practices to actually treat income. Now, these are ideas in evolution, but to give you a sense of how simple this is, I'm going to suggest 4 ways that we as doctors can actually intervene in our offices with the individuals sitting right across from us in their poverty. And my hope is that after hearing these, no doctor will again turn to me and say that poverty is not a disease they can treat. So let me start simple. Ask and listen. A couple of months ago, a young guy came into my office complaining of a sore back. He was dressed pretty funky. He had clean, slim jeans, a nice t-shirt, neatly coiffed hairdo, a nicely trimmed beard. He could have been some hipster barista. But then I asked him about his social situation. It turned out he had no income and he was living in his car. He'd actually come to Toronto 6 months before from a smaller town, hadn't been able to find a job, had no family or supports in town, and he was near complete collapse. He was too embarrassed to go home. I never would have found out any of this if I hadn't asked specifically about his finances. Now, I started asking all of my patients about their income a couple of years ago, and I've been consistently surprised. There's often very little correlation between what someone looks like and how well off they are. And through this simple question, I immediately identify my low-income patient's major health issue. And then I listen to their stories. Sometimes these take longer than I have booked for an appointment. Sometimes they're disjointed and hard to follow. But this is essential to my practice. I haven't lived the lives many of my patients have lived. With their stories, they tell me what they want and need. How else would I have known about the sign on Wanda's door, or Teresa's childcare dilemma? It is through those stories that my patients guide me to what I can do to really improve their health. So that's my first intervention. Ask and listen. Once I have a sense of what's going on, I prescribe. Not drugs, but social cures. Income, housing, social supports. For my patient living in the car, I prescribed an application for welfare. I hooked him up with a community agency that had a housing worker and an employment program. I prescribed him websites and phone numbers to access to look into what other supports he might be able to access. I developed my skills in prescribing income the same way I developed my skills in treating chronic disease. I stay on top of the latest in welfare reform, changes in income security benefits programs, the ins and outs of disability support applications. And I've seen the impact of these interventions over and over again. A doubling of someone's income just by applying for disability supports. Access to myriad benefits simply by filling out an income tax application. The health impact of these interventions is remarkable. But I can't do this alone. So third, I build a poverty team. Now, this is something we've been doing with diabetes for years. We have diabetes teams that have tentacles that run through our clinics, into our hospitals, and out into our communities. And we're now starting to do the same thing with poverty. I work with nurses, social workers, dietitians, and others, and all of us have developed our skills in treating income. And we know who in our community we can refer our patients to for help with their income security. In the last couple of months, we've even developed a position in our team for a dedicated poverty specialist. This is someone whose specific job it is to help our low-income patients improve their income and their savings, and to help us increase our skills in doing this. This will be a huge step forward, an actual health dollars funded position geared towards treating poverty as a disease. But the answers to my patients' poverty will not just be found in our offices. We really need to look to government programs and big social change. And as doctors, we need to demand this change. And so this is my fourth intervention. While I and my colleagues during the special diet clinics saw the immediate impact of our interventions on our patients, we never imagined that that program was the answer to those patients' poverty. We use those clinics to pose a direct challenge to the government that we will not stand idly by and watch our patients die of poverty. We spoke with media, we met with elected officials and bureaucrats, we wrote op-ed pieces in newspapers, and we participated in direct actions and street demonstrations like this one, where we banged our heads against a figurative poverty wall. And when the government stopped us from being able to carry out those clinics, we continued to demand big-level change. We brought the urgency, the legitimacy, and the expertise of health professionals to the forefront of conversations about addressing poverty. And we made it clear that poverty is not just a moral issue, it's a health issue. And until we see our patients' poverty improve, we will not see their health improve. So that's what I can offer as an approach to doctors intervening in poverty. Ask and listen, prescribe income, build a poverty team, and demand change. And it's in this work that I finally found real satisfaction as a doctor. I don't think we're going to systemically eliminate poverty through these kind of interventions, but I finally found a way in my day-to-day practice to feel like I'm actually dealing with what my patients want and need, and actually starting to see improvements in their health. This is what I'm hoping my profession will accept at the core of our duties to our most vulnerable patients. It's what I'm hoping that all of us, all of you, will take as a challenge into your own worlds. And this is what I tell my kids when they ask me what I think will help Sarah the most. Thank you.